Hello everyone. It is week 5 and I am late getting this to you, so I apologize for that. This week we are talking about illness and suffering and dying. And I know because I've already been getting some of your reflections from the movie Wit that many of you have already watched the movie. And I look forward to reading your thoughts on the movie. So today I just want to check in a little bit about the readings for the week. One thing that really struck me in chapter 8 in the Faribault reading was in talking about the wear and tear on our bodies as we age. It reminded me of how often in the hospital when doctors would talk about patients and their seeing the patient, the physical look of the patient. Sometimes they would say that the patient appears much older than stated age, right? Or sometimes would appear much younger than stated age. That shows that sometimes people look very healthy in their 80s, and sometimes someone in their 50s or 60s can appear to look very old. And sometimes this is even just that internal, right? So their organs, their function, their body function is of a much older person or a much younger person. So that really stood out for me in how I would hear doctors describe the patients. I'm also reminded of just how our immune system changes as we age, and certainly in Minnesota and in the Midwest, we see that just with older folks who are worried about being out at church, for example, because of catching germs and getting sick, right? Their bodies are just not as strong as a younger person's, and so even common colds and other viruses that go around can be very fatal to an elderly person. And so we often see these folks less in the wintertime because they're trying to stay healthy. They're also afraid of falling out in this weather, with ice and snow, and they're afraid of falling and breaking something, which often requires a lengthy hospitalization as well as potentially a long time in rehab to gain their strength back. And so older folks are very, very careful. And sometimes the outcome of that means that they're more isolated. And so we need to think about ways to reach out to those folks, especially during those winter months that can be so hard on our parishioners. Another thing that I really can identify with and seeing happen often in the hospital is that recovery time from illness or surgery is so different from what it was decades ago, right? Somebody might have been, not too long ago, a heart surgery, somebody would be in the hospital itself for 6 weeks. These days, people have major heart surgery and they can be home in a week. Being able to get them up and get moving the day of surgery, or at most the day after surgery, for some patients and their families can feel very surprising, and sometimes family members can feel like the nurses or doctors are pushing their loved ones too hard, right? They shouldn't have to get out of bed so soon. But what we've learned is that getting up and walking is one of the most important things that we can do after surgery in order to speed healing and recovery, and in order to prevent sort of post-surgical complications. So as a pastor, being able to help parishioners, whether they're the patient or the family member, just help them understand, right, that this is good medicine. This is going to help them get better, and that it is not cruel and unusual punishment, though it might feel like it. I also want to say that this particular book, the Faribault book, was written in 2008, and it is now 2019. And so some of the research might be dated that they talk about. There's more recent research out there on all of these things, but also even some of the sort of treatment plans. And just as an example, in the breast cancer portion, it mentioned that the first step is surgery for breast cancer. And really today that's not the case. That most often folks have chemo and or radiation even before they have surgery. So I just want to let you know that there are some things in the reading that might not seem accurate to what you might be familiar with today, and I would agree that some of that material might be a little dated. Let's see. Being mindful that illness, injury, surgeries, I mean, you've got the patient in the bed and you've got their family members. And so being mindful of the entire family system that you are providing ministry to, and not just the one person who might be in the hospital bed. Sometimes consideration isn't always given to perhaps young children or teenagers or parents, older parents of somebody who might be ill with cancer, and being able to attend to all of those different generations and thinking about the larger family system is really important in your work as well. The studies, they mentioned the Harold Koenig study at Duke University around faith and healing. And of course there are even more studies since then that do support that patients who have a faith tradition, and this isn't just a Christian tradition, but patients who have a faith tradition, beliefs, practices, rituals that are important to them, do show faster recovery time, fewer hospital days overall. There are many studies out there that support that. Chapter 9 talks about suffering and grief. The author writes that God does not cause suffering. It is not a punishment for our sins. There are a lot of people out there that believe that suffering is because of our actions or behaviors, that it is punishment for, that illness is punishment for our wrongdoing. It's important that we be able to have those conversations with our parishioners, right? Because you might have parishioners who feel that as well. And being able to help them talk through and understand sort of what does suffering mean to them, what does God's presence in our suffering mean, right? And how can we work through that is going to be challenging for some folks, right? Of course, we're not going to be able to talk about grief without talking about Elizabeth Kubler-Ross's 5 stages. Now, in her book, when she first wrote it, her work was not about loved ones and not about grieving after death. She initially identified these stages as she was working with patients in the hospital who were suffering after learning of a terminal illness, right? And so she talked about the different places that she found those folks, right? Whether they were in denial, acceptance, and anywhere in between, right? Now, over the decades since her research and her work, it has become fairly common to talk about these 5 stages as 5 stages of grief, right? So after a loved one's death. The important thing to note is that these are not literal stages that people go through. People bounce around even in a day between any of these emotional places, right? Whether they are in denial or depression or acceptance or any of them, right? And it's important to be able to help identify maybe where the person is, what they're feeling in that moment, normalize how they're feeling in that moment, and just work with them where they are, and help them understand that today they might be one place and tomorrow they might be another, and it is all okay. As it stated earlier when we talked about reinvesting in oneself, right, after death, this chapter also talks a little bit about that, right, being able to, it talks about reconciling, right, to be reconciled we must begin to live again, to move away from the grave and back into life, as it states on page 111 in the book, right, so reinvesting in life. I want to talk a little bit about death. Death for us today is something that usually happens away from home. Now, that was not the case 150 years ago. Um, Death happened at home. Families lived together, different generations, and a dying grandparent was in the midst of the rest of the family as they lived their lives. Today, in moving death to the hospital in many cases, or the nursing home or a hospice program, right? We've moved that experience away from home, and we've made it more clinical and more fearful. Now, granted, it is a good thing that we have medicine, and medicine has allowed us to live a lot longer, to help us live healthier lives. People who would have had an illness that, 3 decades ago would have meant death, imminent death. Now people can live months, years, and decades with an illness. And some of those illnesses we've been able to actually have more curative efforts along with it. So medicine has done fabulous, fabulous, marvelous things. And because it's so good, it can also make the dying or the decision about medical care more difficult. And what I mean by that is that people who have a chronic illness, every time they're hospitalized and they recover, the patient and the family start to believe that it's just another hospitalization and they're going to be okay. And that gray area of, are we prolonging life and improving quality of life versus are we preventing death and moving to suffering instead of quality of life, those decisions get harder to make every time somebody recovers from a hospitalization. Let's see here. I worked with many, many nurses at their first death experience, even in their personal lives or their professional lives, right? These folks they'd be in their mid-20s, late 20s, and had never experienced a death. And I think that is just more and more common. And again, people are living much longer than they used to, and that means that many people have not had a close loved one die. And that can be very traumatic. Anytime it's traumatic, but certainly, that first one when we're older, again, it just seems so foreign and unusual that we don't really know what to do with it. Another thing that we talked about in the book, I think this is now in the other book around end of life, is a code. So in the hospital, when someone's breathing or heart stops, they call a code, and the code team comes, the doctors and nurses, and they do CPR and maybe intubate them if they need to, put a breathing tube in, provide medications to restore breathing or restore the heart function. Now, TV would lead you to believe that these resuscitation attempts are always successful or almost always successful, and the reality is that they're mostly unsuccessful. In other words, somebody who's already in the hospital, if they have a code event, a respiratory or heart stop, the reality is that only 17% of those folks will actually reach a point where they are able to discharge from the hospital. And even at that, most of those folks are going to extended care facilities, right? They're not going home. And so many institutions across the country have started shifting. There's a physician order called a Do Not Resuscitate, a DNR. And physicians will talk to family members about a DNR status if they believe that it would not be successful, right? But a lot of times this designation has shifted to be a DNAR, which is Do Not Attempt Resuscitation. Because in calling it a Do Not Resuscitate, it gives the families this false belief that resuscitation is going to be very successful. And the reality is that they're attempting resuscitation. And so that's a shift that's happening in the medical community from a DNR to a DNAR. And maybe you've encountered that already in your work or in your personal life, but certainly in your ministry, that is probably something that you will learn more about. I think we've talked about advance directives before. I'm going to lift them up again as how important these are when it comes time to have those decisions made. Families that have advance directives from their loved ones feel a greater sense of peace and comfort that they are honoring their loved ones' wishes. For those folks who don't have advance directives and the individual, the patient, is not able to speak, and right, so it's maybe on a ventilator or unconscious and not doing well, and so decisions have to be made. Those are the families that we often spent so much time in the hospital working with them to help them get on the same page with each other, and to get them to be able to make a decision in the best interest of their loved one. And in the process, sometimes that could take days and weeks, and therefore the patient is suffering spiritually as they're sort of one foot here and one foot in the afterlife, waiting for the family members to come together and make good decisions for them. And so really I want to enforce just the importance of talking about advance directives. This is one area as pastoral caregivers where you can really encourage your congregation members to do this work, right? So that their wishes are known and so that their families don't need to make those decisions by themselves. They have the input from the loved one in their own words. What else do I want to lift up for you today? I want to talk a little bit about what happens when a body is dying. In the hospital, I would teach a class on sort of about the dying process, the spiritual, emotional, physical aspects of dying with the new nurse graduates in the hospital. And one of the things that comes up is, we might make all these decisions about end-of-life care, the things that sort of really, where people get hung up on, where there's really this emotional attachment, is to food and hydration, right? So nutrition and water. Those are some of the aspects that people have the hardest time in letting go of when making decisions about end-of-life care. So when our bodies are fairly healthy bodies, yours and mine, our bodies need food and water because it is living. It is continuing to live, and it needs the food and nutrition to do that. When somebody is ill, either ill or recovering from surgery, recovering from an injury, our bodies need even more nutrition, right? Because our body is working hard to heal. So even when we're fighting infection or fever, anytime our body is working in those ways, it requires even more nutrition, more calories, because it's working harder, it's burning more calories. Now, when our bodies are dying and shutting down, we don't need water, we don't need nutrition. Again, our organs are not doing the work of living, our organs are doing the work of shutting down. And in fact, water and nutrition introduced into a body that is shutting down can actually cause more harm, because we're putting these things in our bodies, in the body, but they're not actually getting processed and coming out, right? So we can add, it can cause increased swelling and discomfort, right? Families have a hard time with that, right? Because they think that that not giving water and food is causing suffering. Helping them to understand that it is not what their loved one's body needs right now. Sometimes we introduce food and water for comfort, right? So some swabs, a little food if they're able to get it in their mouths, but again, we don't want to cause choking, so we need to be mindful of that. But helping families understand that the work of the body now is to shut down and slow down. And so the body is not feeling hunger, it is not experiencing thirst in the way that you and I would experience those things if it was kept from us. But it's a very emotional topic. Usually people are okay with things like stopping medication, stopping heart medication, stopping antibiotics. It's the food and water that tends to be the more emotional tug. And so being able to help people cope and understand with that is really important. And a little bit about chronic illness and just how that impacts the family system overall. Again, the frequent hospitalizations, the continued gentle decline of one's abilities, and all the losses that involves over time, right? Having to work less, eventually giving up work, maybe not being able to go watch your kids or grandkids in their sports events or music or band events, right? Any of their programs, because you don't have the energy. Things that family members give up in order to help take care of the one who is ill. All of these things, right? It's just, there are so many aspects of life that are impacted by chronic illness. And again, because medicine is so good, right, we can, people are living much longer. And so those chronic illnesses are becoming decades chronic, where again, 30 years ago, a chronic illness might have been 8 years, but now a chronic illness can be 30 years. And just being mindful about how that overall impacts the mind, body, and spirit of everybody. I think that's all that I want to tell you about the readings this time around. As I said, I know that many of you have already read or watched the movie. The discussion posts are up there. I have not looked, but they are up there, so I look forward to reading some of your discussion posts as well. Remember that our session on this coming Monday, the 11th, is another live session. I'll get that meeting set up with Deb DeMeester's help for 7 o'clock. That will be our final session. We'll talk about your genograms a little bit and also be able to talk about sort of any other questions, comments, thoughts, reflections that you have about the course overall. So I look forward to seeing you all on Monday, March 11th. I know that here in the Twin Cities, this Saturday we are expecting more snow. So I imagine that there is snow going through other parts of the Midwest as well. So for Iowa and other parts of Minnesota, I hope that you all stay safe and warm. And I look forward to seeing you all on Monday. Take care.